Okay, so now we're going to move on to the actual pharmacology and drug classes of antidepressants. We talked about the different ways that we can modulate monoamines, and just because this is a different video, I'm just going to put this in here real quickly. You can modulate the synthesis. You can modulate the action at the postsynaptic receptors via agonists. You can block postsynaptic breakdown. You can block reuptake. And you can block presynaptic breakdown. Every one of those things is going to increase the synaptic transmission there, or the signal there, even if it's not actually increasing the level of neurotransmitter itself like the agonists won't, but it'll increase your signaling. So when we talked about these monoamines, we said all three were monoamine oxidase, were monoamines. So all three were going to get broken down by monoamine oxidase. Then we're going to talk about three drug classes: tricyclic antidepressants, SSRIs and SNRIs, and then some kind of random drug classes that we've added on. So you guys will be seeing antidepressants for a lot of different things. It's not just for depression. They can definitely be used for bipolar disorder as well. But you'll be talking about how in bipolar is the depression in bipolar is a little more complicated than it is for major depression in terms of treatment. And so you might be using some other drug classes for bipolar depression. Even though they are designed as antidepressants, they're really highly used for anxiety disorders. And so, again, we know these are increasing serotonin. And with serotonin, it seems to be anxiolytic, it decreases anxiety. And so while antidepressants take a couple of weeks to work for depression, they actually act very quickly for anxiety. So whatever they're doing for depression versus anxiety is actually a little bit different. They're acting on different pathways or acting a little bit more directly for anxiety. Also use them for bulimia, neuropathic pain, fibromyalgia, lots of different things. As long as it is something you can see the when we talk about pain and we talk about fibromyalgia, you'll see that these have some serotonin and norepinephrine components. And so understanding what these drugs are doing is going to help you understand why would you use an antidepressant for a nerve injury. So here is the great thing. I made you this. You can thank me later in person, but this is how I like to look at the antidepressants. So I like to look at them as less specific and more specific. And so less specific would be a drug that affects a ton of different things, and more specific would be a drug that affects only a couple of different things. And that would be, hopefully as a pharmacologist, our goal would be to be just as specific as we possibly can so that we don't get adverse effects that we don't need. You do know that we're going to be talking about drugs that act on serotonin pathways, norepinephrine pathways, and dopamine pathways. And we've got the drug classes, monoamine oxidase inhibitors. We're going to talk about tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors, alpha-2 adrenergic antagonists, selective serotonin reuptake inhibitor. So selective serotonin, way more specific than a serotonin norepinephrine, which is way more specific than an MOI, which was dopamine, serotonin, and norepinephrine. Then we've got some other ones that are kind of newer. We've got these SARIs. I will talk about what that stands for because I actually don't remember at this very moment. And then a couple of new drugs that do work with depression, but actually are more likely to be used for other types of disorders, not depression. So we're going to talk about this NDRI, noradrenergic dopamine reuptake inhibitor, bupropion, and noradrenergic reuptake inhibitor, atomoxetine. And we're going to talk about that when we talk about ADHD. So as we're less specific over here, we remember that our monoamine oxidases were all three of these neurotransmitters. So if you're blocking monoamine oxidases with a pretty high dose, so it blocks monoamine oxidase A and monoamine oxidase B, then you're going to block the breakdown of all three of these. And you're going to have some pretty good increase in all three of these. But we do have some side effects, and some of the side effects of antidepressants that are really major are going to be, some of them are going to have some are going to have some antagonism at histamine receptors, so they're antihistaminergic, antimuscarinic, antiadrenergic, and they can be sodium channel blockers. So not only are we looking at how selective are they within these three monoamines, we're also looking at how many other types of binding effects they have. So our MAOIs have always been considered pretty dirty drugs. So then they went ahead and made TCAs, tricyclic antidepressants, because they were cleaner drugs. They only blocked serotonin reuptake and norepinephrine reuptake, and then didn't have any effect directly on dopamine. There's little bits of circuit effects, but we're not going to talk about those. They're really minor. So when you're looking at TCAs, you're looking at blocking reuptake of these two. But you can see it has a lot of side effects, lot of H1 antagonism, a lot of antimuscarinic, alpha-1 antag, and sodium channel blocking. So that's going to give you some side effects right there. So when the med chemists looked at that, they were like, no, we want to block reuptake of those, but we cannot go around having all those side effects. So they created SNRIs, which also blocked SERT and norepinephrine reuptake transport, but didn't have a lot of these side effects. So still an H1 antagonist, but a lot better than the TCAs. Then we got a little bit more specific, and they were like, okay, we still want to increase SERT and increase serotonin and norepinephrine, but we want to kind of make it not everywhere in the brain. We want to kind of pick and choose which brain regions and which synapses we're going to change it at. So we can't just completely block reuptake. That'll block it up everywhere. So we're going to look at some drugs that have some kind of more complex pharmacology, like this alpha-2 antagonist has some circuit effects on serotonin and has some circuit effects on norepinephrine. But those are going to be much more specific to particular brain regions and not everything. So we would figure that is more selective than an SNRI. SSRIs are what we most commonly see, and those just block serotonin reuptake. SARIs block two different effects on serotonin. They have two different effects on serotonin. Not only do they block reuptake, but they're also an antagonist at certain subtypes of receptors. So you're increasing serotonin levels in the synapse, but you're blocking some receptor subtypes. So you're only getting increased serotonin signaling where you want it and not where you don't want it. I think maybe I should draw that out. If you have one pathway here and another pathway here, they're both serotonergic pathways, but they both do different things. And say you have 5-HTX and 5-HTY receptors, and they're releasing serotonin. Yeah. Okay. If you have this agent that just blocks serotonin reuptake, then you're going to get a lot of serotonin in both of these synapses, both of these pathways. But if you have a drug that blocks reuptake and antagonizes this receptor, then that receptor doesn't care that you increased serotonin levels because that signaling is blocked anyway. So now you get increased signaling here because you didn't block it, and you've been able to selectively increase serotonin signaling with one pathway and not another. So when we come back after I am fully recovered, then we'll be able to go through any questions you have about this. And don't worry, this is not all you're going to see about it. This is just the